So where are we with COVID? This is the worst pandemic in our lifetimes. The worst pandemic certainly in 100 years, probably the worst pandemic in the history of the United States. Hard to figure out if smallpox was a pandemic at that time or just a really bad endemic disease. So we are today encroaching 200,000 cases a day in the United States, well over 500,000 cases a day globally. I was on a call yesterday morning with the Director General of WHO, Tedros, and a group of people that form a group called GORN, the Global Outbreak Response Network. Every other Wednesday morning, we go around the globe and get a report on how is it in Singapore, how is it in Russia, how is it in India, how is it in Latin America, how is it in the United States and China. It's really a tale of two cities. East Asia is feeling extremely uncomfortable because they haven't had a case in days. Vietnam went 100 days without a case. Singapore went 200 days. Taiwan went 200 days without a case. Singapore today is over a month without a single case of COVID. And so they look at us in the United States and Germany, which is having an explosion right now, and the UK, which is just beginning to dip after a huge peak. And they basically say, what the fuck's wrong with you people? They don't understand. They don't understand how we could have blown it as badly as we have. And we have indeed blown it really badly. We are in the United States, we will pass 90,000 patients with COVID in hospitals. We don't have any more hospital beds in parts of the United States. I grew up in Detroit, Michigan, and one of the hospitals that I trained at in medical school was a hospital in Detroit, Michigan, and it's still around. And in May and June at the peak then, in Detroit, there were refrigerator trucks that had to come up and drive up to the morgue of the hospital and were filled with dead bodies because there was no more room in the morgue. I'm sorry to say that, and we'll have a lot to talk about of all the things we're grateful for. I'm not grateful for the fact that the next month or two will be filled with images of refrigerator trucks because the morgues and the hospitals will not be adequate to hold the bodies in the United States. We really messed it up badly. So much of this was unnecessary. And I try to think of, literary allusions for this group. I think that right now Sisyphus would be a good one, and trying to keep that rock from falling on our heads. Maybe Tantalus, as that poor fellow kept on reaching for the grapes, the victory that eluded him. But I also think that this idea of a Dickinsonian moment of the best of times and the worst of times is a useful image. And it's the worst of times clearly because this is not the peak of the epidemic. This is Everest Base Camp. We're going to go to Everest before the vaccine arrives, before the cavalry arrives, the heroes arrive, the scientific heroes arrive. It's clearly the worst of times so far in the pandemic. In the world, every day we set a new record of the number of cases, number of deaths. Every day in the United States we do. So it's the worst of times as far as the pandemic is concerned. But it's the best of times because just as a virus moves at exponential speed, so has science. I mean, just take a moment to think of what really happened. MIT keeps track of all the peer-reviewed articles on COVID. It succeeded 60, 80,000 articles, and many of them are really good. Lots of them are really good, maybe not all of them. We have 3 vaccines. We have 146 vaccines that are in some form of trial. We have 3 that have passed the milestone of being put into the arms of tens of thousands of people with relatively minor side effects. The mRNA vaccines, the 2 from Moderna and Pfizer, have had, modest side effects. We're not sure about AstraZeneca. There's some issues there we could talk about. Although it's undoubtedly a good vaccine with efficacy. We don't know exactly how much. But how quickly we've gone. For those of you who don't know, the previous world speed record in getting a vaccine was the mumps vaccine, 4 months. We had the smallpox vaccine for 200 plus years before we had vaccine programs on a global scale. We had the polio vaccine for 70 years before we had vaccine campaigns, as we do now. We're going to have a vaccine campaign in 2 months. We're going to go from this novel virus disease didn't exist to a global vaccine campaign in 14 months. And what about the speed of monoclonal antibodies? We're barely into a world that can understand what a monoclonal antibody is, and we will have 2 at least, and many more following, treatments that really appear to work if given in the right way at the right time and the right, all those things. And our use of diagnostic testing, just again, to put it into perspective, the tests that we're talking about that everybody is maligning, and Trump is saying that the only reason high case counts is we are using more tests. These tests are tests historically that are used to confirm diagnostic hypotheses. A patient comes in to see me as a physician, and I think maybe they might have diabetes, and I do a glucose test, or I do an A1C test, or I do some kind of a lab test to confirm the hypothesis. We are now using these tests to make the Democratic Convention safe. We're using these tests to get Hollywood productions back. New Zealand and Taiwan are using these tests to exclude people from coming. They're in a good way exclude, maybe the only time I could ever use the word exclude in a good meaning. We're using these tests in a totally different way, and whether they're PCR tests or antigen tests or CRISPR tests or lab tests, there is such an explosion of these tests that we now don't even have enough place to store all the antigen tests, let alone find the right exact way of using them. The $5, 10-minute at-home test is really right around the corner, a couple of months. Vaccines, treatments, testing, the science behind it is breathtaking, and the speed at which it has accelerated is unprecedented. And it is equal to the challenge of the problem of a novel pathogen that jumped from a zoonotic host into humans. We're not going to be able to do a classical eradication program, even with all of that, because the virus appears to infect not just bats, not just civet cats, but mink and cats and non-human primates. And while we're not sure if that is a two-way infection, that humans can infect minks and minks can affect other minks and then infect cats and then infect humans, it's enough of an asterisk that the programs that we will be mounting globally, which will be the largest vaccine campaigns in history, if you take into account the space of time in which they'll be done. We have to vaccinate somewhere between 5 and 7 billion people, most of them with 2 doses of the vaccine, many of them with annual boosters. And we have to do it right now with 2 vaccines that are ill-suited for that, Moderna and Pfizer, because they require refrigeration at -80, -100 degrees. That's why there's a lot of interest in the AstraZeneca vaccine, because if it could only be one dose and didn't require more than modest refrigeration, then it could be the global vaccine that we need, and it probably won't. None of the vaccines that we currently have will be perfect, but like everything in science, we will grow, increase, improve iteratively, and we will get there. So it's the best of times for the science. It's the worst of times for the history of the disease, looking at the epidemic curve and the death rate. And the reason, and then I'll end my little introductory spiel. The reason that it became the worst of times is there's several components to that. One, we are living in an age of pandemics. Every year, 2 or 3 or 4 viruses of animals, zoonotic viruses, jump from animals to humans. And some percentage of those are innocuous, but a high percentage of them are bad. And somebody's going to write a poem or a song that's going to get all these names into one song, like that phosphorus essence song on all the elements, that element song. They're going to say Zika and Ebola and West Nile and Lassa fever in Marburg and H1N1 and H5N1 and H7N9 and swine flu and bird flu. You don't want me to keep going, but those are all the zoonotic diseases, HIV/AIDS, that didn't really, in an important way, exist in humans 4 decades ago, 3 decades ago, and 1 decade ago in many cases. And there are going to be more, and that it's going to grow. Ironically, 30 years ago, the Surgeon General of the United States said that we've ended the age of infectious diseases. This is a growth period for infectious disease doctors, unfortunately, virologists, epidemiologists. But we're going to have more of these diseases because there are more human beings, because humans have entered into animals' territory, because we're cutting down rainforests and we're eating more bush meat and exotic animals and more meat, and because we have transportation that can take what used to be an isolated event occurring somewhere in a forest and bring it into Manhattan in under 16 hours from almost any place in the world. So we need to learn from the lessons that we've learned in watching science travel at an exponential speed on this pandemic. Unfortunately, we will have occasion to use those lessons going forward in the future. And that leaves me with what I think is the most optimistic of the best of times, worst of times framing of this. And that is Ron Klain and the people like Ron Klain, who was Ebola czar and is now chief of staff of President-elect Biden, and the people who are the scientists who are now replacing the political operatives who ran what was supposed to have been a task force. We're in the problem that we're in because of these long-term secular trends of animals and humans living in each other's territory and viruses jumping from animals to humans. But we're also in this short-term secular trend of nationalism. And maybe this is open up the conversation to everybody. In my, I'm not a historian, but I love history. And in my view, something happened after the Second World War when the concentration camps became under scrutiny and we all watched the skeletons come out of the concentration camps. We watched the firebombing of Dresden. We watched the mushroom clouds over Hiroshima and Nagasaki. We witnessed the awesome power of technology in the midst of war and hatred and anger. We saw the brutality and the ugliness and the horror of the fascist regimes. And there was no singular event, I don't think, like one of John's magical events or Steph's magical events. There was no singular event, but it seemed as if humanity whispered to each other, let's never do that again. We've looked over the precipice and we've seen the gates of hell. Let's not do that again. And we created all these institutions to act like glue or to bind us together, to kind of deal with the centrifugal forces and to make them centripetal. We created the United Nations and Bretton Woods and the World Bank and FAO and UNESCO and UNICEF and the alphabet soup of all these agencies and organizations. NATO. There was a CATO too in those days. We created all these alliances and partnerships and global communities to bring us back together and to stop these things that were pulling us apart. I think this is a good example. I think Katinka and John's whole universe is another example of the kind of sisterhood and brotherhood of globalism, global intellectualism, and global economy. But over the past few years, it hasn't worked for everybody. And so we now have centrifugal forces that are pulling us apart. It's, Putin and Erdogan and, Bolsonaro, Trump. These are all, Brexit. All these are symptoms of the centrifugal forces pulling us apart. And that's not my lane. That's not something that I know a lot about. But as an epidemiologist, it's the worst thing that could happen to us. We need to have a strong WHO. We need to have a strong United Nations. We need to have a strong Gavi and the Global Fund and all these different organelles that make it possible for us to deal with global threats. I would extend it a little bit out of my lane to say we need it desperately to deal with climate change and nuclear proliferation and drought and famine. But in the area that I know, in pandemics, we can't stop a pandemic without having global collaboration. And we have failed to learn the lessons of Taiwan and Vietnam and Singapore and Korea and New Zealand, Iceland, the countries that have done really well, because we don't have a strong way to take the best lessons from the success stories in dealing with this pandemic and globalizing them. Because we deal with disinformation, because we hold up the Swedish example, because we all love Sweden historically, and in this case, it wasn't a good example of how to deal with the pandemic. Because we don't have a love of science in the leadership of the world, because we don't talk to each other in the way that we need to. So that's my way of tying together the peril of the moment that doesn't end with Trump's defeat, although it's certainly better. It doesn't end until nationalism and the forces that pull us apart are seen for the danger that they pose to the worlds that we want to live in. And I only offer the pandemic as one exemplar. God help us when we deal, as we must, with climate change in a world that's being torn apart by nationalism. But I'm really optimistic compared to 3 weeks ago. I don't know about you guys, but I don't wake up with the same sense of dread every morning that I did before this election. This was the first WHO meeting of this group of elders that I'm part of since the election. And I almost cried as we went around the world and people were talking about how they were doing on the pandemics. Not a single country failed to say to the Americans on the call, welcome back. We've really missed you. John, over to you.
I'm back. All right. Sorry. JJ?
Yeah, thank you, Larry. And I really liked in your first talk when you said we shouldn't be thinking about this as a peak. Remember, you said it's a wave and it was more like a tsunami, and now we're in the third wave. And it feels like that messaging really replaced the peak idea, I guess, because there were many to follow. And I know that some of the early mistaken messaging around surfaces and germs have been replaced with like Mike Osterholm's "Don't Swap Air" I've seen in the last week or so. And I'm really curious about this latest, what you mentioned from the WHO call, sort of East-West divide. That doesn't seem to really be true given the New Zealand and Iceland examples. And I worry that some of this is getting attributed like, well, the Eastern countries are going to do so much better than the Western, but we have these cases of Western countries that have gotten COVID under control. And you mentioned that. And so I'm sort of curious how that narrative is playing out in your world.
Well, all the Western countries that have done well are run by women. I think in being islands helps. Germany had been a really great example of a success story run by a woman that was not an island. Now it's having a big problem. No, I think it isn't the countries so much that should be the exemplars, although it is resident in that country, but it's what they did. So for example, and there's so many ways to defeat this virus. You don't all have to do the same thing. In Vietnam, they weren't very fast in dealing with it, but they were incredibly meticulous. They would do contact tracing of 100% of contacts. So they would find every single contact of every case and find them and either quarantine them, isolate them, or in some other way remove them from the density of susceptibles. The success in Taiwan is almost entirely due to speed. They would respond so quickly to any new case that even though they may have been less careful than the Vietnamese system in isolating or quarantining, they were so fast that speed is what made it work. I think Iceland benefited from a long history of genetic information and a great database. So they were data-driven. And in New Zealand, they used exclusionary methods to keep the test, to keep the virus from coming in. In Singapore had two very different cultures. The regular Singapore, which has a kind of built-in self-policing, I think is the best way to say it, where individual volunteers pointed themselves as citizens going up and down the street, and if they saw somebody without a mask, they would report them. But then they also had guest workers who lived in cramped quarters and very hard and unsanitary conditions. And the epidemic kept on increasing among the poorest and most vulnerable in the guest quarters, leaping back into Singapore proper, I guess, until they understood that. And then they did something that we've not been able to do, which is they decided to improve free housing, give free food and free quarters for anybody who was sick with COVID, which you think of as a very, of course, but nobody else does that in the way that they did it in order to stop the disease. So there's 100 different ways to defeat the virus. We just need to do best practices that others have already innovated. And, I'm reminded of the polio program and the guinea worm program and the smallpox program, which started off in every case with flawed hypotheses. And in no case did those programs begin with the plan that they ended with. But because they had a porous kind of governing structure where anybody who had a good idea, that idea would immediately be tested and then socialized and spread everywhere. That's the way a big program like that on a global basis works. And we've gotten so many great ideas and innovations. They happen to, yes, come mostly from East Asia right now, but not exclusively. And they happen to come from countries that are run by women, but not exclusively. But we don't have a structure that does as good a job of gathering those great ideas and socializing them, and then having the political will to follow them. So you're absolutely right. It shouldn't be East-West. I would joke sometimes that the virus hates totalitarian structures more than it hates democracy. But the virus hates everybody equally if you can anthropomorphize the virus that way. But you're absolutely right to not make it into an East-West thing.
Francesca?
Yeah, thank you. I have two questions about the future, even though I don't want to put you in the position of trying to make guesses, because it's a situation that is dynamical and it's difficult to make provisions. But I have these two questions. One is on the short term, somehow, how much our life will kept on being changed. How much are we not gonna come back to the old way of life we had before? How much do we have to take precaution in the future for this virus? So this is the first question. And the second question is more related to what you were saying about nationalism. And nationalism is always fueled by capitalism. And in this moment, there is a lot of reflection in society about an opportunity here to change society for the better using this particular moment. And on one hand, science can be used to cover totalitarian moves, like to control more people and possibly to turn our society into a more controlled one, using the virus as an excuse, possibly. But on the other hand, there is always also a lot of discussion in making society more democratic, more free, and change our way of life into a more ecological, more sustainable way. So what's your feeling about this?
Well, I think the second one first, if I could. I mean, I don't have a clever way of freedom without. Wait. I guess it was a slogan. Maybe New York Times had it. Vigilance is the price of liberty. Was that what it was? There's something about freedom, this notion of freedom, as in we can do whatever we want to do as individual, or individualism, some combination of individualism and Ayn Randian kind of notions of freedom, I guess, that they don't go very well when you're dealing with threats that are a loss of public goods or market failures. There's no, the structures to deal with climate change don't exist inside of capitalism or any individual enterprise. The same thing is true for vaccines. Vaccines are public good, but it's not really in anybody's individual interest to be the first to take the risk of trying vaccines or even to fund the research on them. So we don't have the organizational capacity to deal with a class of problems that modernity has brought us, that into which this kind of a pandemic and climate change and maybe some of the droughts that we've looked at fall. So I don't know the, of course I don't know the answer to your question at all. But I do worry that if you add to this already uneasy relationship between freedom and accountability, or freedom, individualism, and global welfare, if you add to that already uneasy equation massive disinformation, social media that can disseminate disinformation so quickly, and the political politicization of calamity, we've not dealt with it. We've just not dealt with it, and so I worry about that. I mean, the only alternative I see is strengthening, not world government per se, but strengthening a kind of globalism that the world seems to be reacting against. I want more globalism of this, sharing information, sharing ideas, sharing best practices. I don't know how else we deal with that category of threats that into which climate change and pandemics are two of N, where we could debate what N is and how many there are, but those are certainly two. The earlier question was something like, what does normality look like, and how do we get to normal, and will we be back to where we were? Did I get that right? Is that? I don't know. I mean, I get asked that question so many times that I think people think I should know. I do think that some of the things that have occurred because of this pandemic, one of which is what we're doing right now, will have long legs. Hard for me to believe that the life that I led before, where I would get on a plane and and fly 16 hours for a 2-hour meeting, stay one night and fly back, seems to me like that's less likely to happen now when we can do things like this. When I watch the exodus out of the cities into leafy suburbs, instead of the increasing squalor of a place like San Francisco, which I love, but is hardly at her best moment these days, it's hard for me to believe the repopulation of the cities after a pandemic will occur as quickly as it might have if there hadn't been the opportunity for some set of workers to work from home. So there's some big societal things that seem to have occurred during the pandemic that are likely to have legs, some that won't. I spend a bit of time advising the travel industry, or trying to advise the travel industry, and it's hard to imagine that industry will be as it was before for quite some time. But having said that, it is remarkable how quickly that a change that we thought was taking forever to come, how quickly it arrives when it does arrive. I think there's some famous quotations on that. Once we have adequate vaccines, if they are effective, as we hope they are, and if they have as few side effects as we hope, and if they are not, if they don't become politicized, and let me put an asterisk on that and come right back to that, things will get normal. We live in a normal world before with a lot of yellow fever. And I don't know if anybody on this call has felt your world destroyed by yellow fever. It's a terrible disease. It's worse than COVID, and it does exist. And in the communities that are hit by it, they're ravaged by it, and yet we have a good vaccine. So with a good vaccine and a yellow card, or a digital version of the old yellow card, we got back to life pretty good, dealing with yellow fever, even with malaria, even with HIV/AIDS. We live with diseases that are terrible diseases, worse than COVID in many ways, and still deal with them. Smallpox, until it was eradicated, we lived with smallpox being almost everywhere, and most of us didn't even know it. In the Summer of Love in 1967, the Summer of Love, 2.5 million people died of smallpox. Yet we had the Woodstocks and the Summer of Loves in the middle of pandemics like that, because we had vaccines. So vaccines will transform the fear, the vulnerability, the sucking out of all the oxygen from the conversation, which COVID and Trump both seem to do. The COVID will not occupy all of our emotional intelligence, our emotional time. I think that'll be the biggest change that I can see. And then these others are knock-on effects. I hope that one of the changes will be a reversal of this trend of centrifugal forces in the world, and that we'll be able to, and maybe through technology, to re-begin exploring our commonalities a lot more than we have before. I use best practice as kind of like an exemplar of what the benefits are of recognizing that we're really all in this together. So I just want to mention one more thing about the anti-vax movement and the politicization of vaccines. It's not just Andrew Wakefield. It's not just the Lancet's error in publishing a bogus piece of science that was funded by a bunch of lawyers. That it's not just the conflation of vaccines and autism, which is not true, but is certainly a meme. It's not just that. There's something else that's happened to the anti-vax movement in the United States. For those of you who are not in the United States, you may not know about an event that took place in the state of Michigan, where a group of pro-Trump, anti-lockdown militias, dressed all in military, with machine guns, took over the state capitol, and of course have then threatened to kidnap the governor of the state of Michigan. The pictures of this armed militia in the middle of the state capitol of one of our major states is indelibly etched in my brain, my mind. And to think that that was a protest against the governor's attempt to try to put in place measures to stop COVID, which is really what was the beginning of that. And then Trump fanned the fuels and told, open up, liberate Michigan. But it was how it got started. All of the logistics for that, the money for that, was funded by the anti-vax movement. What? What is the relationship between armed militia going into a state capitol and threatening to take over and the anti-vax movement? Well, the anti-vax movement has an infrastructure. And that infrastructure was energized by, and those two groups, movements in the United States, those two groups came together, and they are now cemented together in many ways. And so I worry about the anti-vax movement and the politicization of it, so that it won't merely be a misunderstanding about a relationship to, God help us, to other diseases, but it's actually a political movement, and it's a strong political movement. So I do worry about that. I don't know if that answers your questions, but John told me to riff.
Lots of things, a lot of things to think about.
Want to get on mute? What do you want?
Can you say more about the infrastructure of the anti-vaccine movement? I mean, is it an organized movement?
It's certainly it has a lot of the accoutrements of a political campaign. There are films, the film Vax with 2 X's, the newsletters, the combination of legitimate, honest concern about how we have packed so many different vaccines, childhood vaccines, into such a short period of time in the earliest days of kids' life. A real honest and legitimate concern, coupled with a kind of selfishness, I guess, where not invented here syndrome. I don't know exactly how to describe it, but why should my child have a 1% increased risk in order to give society a 50% increased opportunity of health? That kind of selfishness that it's not uniquely American, but we seem to have perfected it. I live in Marin County, which is one of the epicenters of the anti-vax movement, so I'm more sensitive to the more benign parts of it. But I don't think Michigan feels like the anti-vax movement was benign at all because of how it was organized. What the relationship is between armed militias in the anti-vax movement is part of a dark underground of right-wing, and not even right-wing. I think the wings are gone. There's no way of accounting for this in classical economic right-wing, left-wing kind of terms. But the dark web is part of the organizing areas for this. We're going to find out a lot more about it in the coming months as more and more COVID vaccines become available. There's good news too. We shouldn't, somebody said that we should celebrate our public health victories more than we do. In the United States, we've now reached almost 80% of Americans routinely wear masks. If that were any other public health intervention and 80% of people used it, we'd be celebrating and dancing in the street, but somehow we're lamenting the 20% instead of celebrating the 80%. In a similar way, I want to celebrate the fact that we've reached 55 or 60% of Americans now say they will take the COVID vaccine, when that was 40 or 42% only 3 months ago. I actually think that's a pretty high number, given a vaccine that didn't exist for a disease that didn't exist, a year ago. And I think it'll increase. So maybe this will be pressure against the anti-vax movement. Maybe this will be a catalyst for the anti-vax movement to become more aggressive. I don't know. I hear all the time that there are people who profit off the anti-vax movement, but I don't know who they are. And I don't quite understand it. It's not like it's the Koch brothers who make all their money from fossil fuels. So naturally they're fighting against fossil fuels. There isn't that kind of clarity. And maybe somebody else on this call knows a lot more than I do. I'm sure there's somebody else who knows a lot more than I do about where the economics lie. The political commonality between the ultra-right in the United States and the freedom movement and I am free to not take a vaccine movement, I am free to not wear a mask. I understand the superficial similarity between those things. They're not very deep and profound, but I don't know more than that.
Larry, can I ask you a simple scientific question about if we go, when the vaccines are introduced, we understand that there will be not very much compared to the demand, and the numbers of vaccine available will grow. Therefore, does the strategy with which the initial doses of vaccine which are available are distributed matter a lot to the course of the epidemic?
Oh, what a great question. So there's two offsetting, in my mind, there's two offsetting dynamisms here. The equitable distribution of vaccine, fair, just, going to the people who need it the most. A wonderful group of people at the National Academy of Sciences, a committee called the Equitable Use of Vaccine Committee, was chaired by Bill Foege and Helene Gayle. And Helene had been the head of CARE, and Bill, of course, was the head of CDC, the head of the Carter Center, and is a saint. Bill Foege is one of the patron saints of public health. These are wonderful people. And they had a great committee. A lot of chairmen of Department of Epidemiology and Ethics were in that committee. And they have published their report. It's available for anybody to see. And they have recommended a cadence where the first group of people to get the scarce vaccine, call it the first tranche, will be first responders and people working in hospitals in the healthcare field. And that is both out of fairness to these people who've risked their lives and out of the practical consideration that if they're sick, we won't be able to advance the program as much. The second group will be those who are most vulnerable at dying from the disease. And then that has some subcomponents in it. And some of them are demographic groups and age groups, people living in nursing homes, pre-existing conditions. And then that cadence goes on and on. So that is an ethically driven calendaring or prioritization of vaccine distribution. It is not the same thing as what we will be able to do once that initial demand has been met. For me, I'm waiting for a kind of boutique, nuanced bit of science to come forward, which is called PEP, P-E-P, post-exposure prophylaxis. I'm waiting to see if any of the 146 vaccines provide post-exposure prophylaxis, which simply means if you vaccinate somebody who's already been exposed and the virus is cooking and will become either a real disease or become a spreader, you can still vaccinate them and abort the disease or abort the spreading. And we've had vaccines that had that characteristic in the past, but they are few. If we have a vaccine that has that characteristic, it will then allow us to do the most rational thing of all, which is to find every case and then vaccinate the people around them. We call that ring vaccination or selective epidemiological control. And ironically, the father of that field is Bill Foege, who also chaired the Equitable Use Committee. We don't yet have a vaccine like that we know for sure, although we're, with 146 lotto coins, we can be optimistic about it. If we get that, then these plans may diverge. WHO is having a big problem because they've only got enough money for 1.2 billion doses of the vaccine in this COVAX agreement, one of these other global consortiums that the US, that Trump pulled out of, and Biden has said he will rejoin. 1.2 billion doses is 600 million people who can be vaccinated. That's less than 10% of the world. But more importantly, WHO is sort of the singular agency, WHO and Gavi, IAVI, these vaccine monopsonies, they're the ones who are nominally taking it as their job to provide vaccines for the countries that can't afford it themselves. So 600 million people is not very much. That's a big problem. I think there'll be plenty of vaccine for the developed world. The US has pre-production purchase agreements for well over 1 billion doses. That's more than enough for Americans. England has plenty purchased. India is going to turn out to be the largest producer of vaccine and has made a commitment that half of all the vaccine that the Pune Institute of vaccine production will be able to manufacture. The Chinese, the Russians, well, we don't know very much about their vaccines. Over 1 million people have been vaccinated in China already. There'll be a profusion of vaccines with different characteristics that'll be very difficult for all of us to figure out which one is the best and which one is the safest. But I think that, as I said earlier, sometimes it takes forever for something to happen and then it happens all at once. So I think we'll see a profusion of good vaccines.
I have a follow-up.
So, quick follow-up. What if one could show that the most efficient strategy was not the ethical one?
Well, we can, I think.
I think we can too.
The most efficient strategy is to do the one that we did in smallpox, which is to and has recently been done in Ebola, which is to find every case and vaccinate everybody who's susceptible. Maybe efficient is the wrong word. Effective. That's the most effective strategy.
Effective.
So I wonder on this same point, I can see the logic behind starting with the most vulnerable, etc.
Can I just say how nice it is to see you?
Sorry?
How nice it is to see you.
Well, likewise, and the rest of you as well. It's been a while since we connected. Yeah, thanks for your remarks on this. On this kind of cadence, the plan for how it would be. So I see the logic behind the approach you outlined. I wonder though, if the main concern is that ultimately not enough people will choose to get vaccinated to achieve herd immunity. If there are a lot of sort of people with anti-vaxxer sentiments, or even if they're not all the way there, they're just maybe you could run an argument that the better approach would be to, well, start with some healthcare workers and nurses, but then rather than going immediately to, say, the most vulnerable people in old people's homes, and what you would rather want to do is to start with social elites, so that it becomes seen as a desirable thing. People see these rich and famous people getting their hands on the vaccine early. Everybody will want it. They see it as a good thing. And then as soon as there are more doses, then everybody will, as soon as they are able, want to have their own families vaccinated. Whereas if you start with the elderly, maybe it's become seen as this thing that weak people do. And that if you're a strong, real man, like who's healthy and young, you don't want to be associated with that.
Yeah, Tesla started off with a James Bond Roadster to make electric cars sexy. No, I understand. So let's talk about herd immunity for a second. There's something funny about the way in which COVID has spread through the population in that it is lumpy. It doesn't spread the way a normal respiratory disease spreads. And whether you're talking about R naught or R instantaneous, or community infection rate, or all these mathematical models that we've had, it's still it's still 20% of people who are sick spread 80% of the disease, and those 20% are, as Nick said, they're probably highly networked individuals, and therefore the first group of people to get the disease, because they have a lot of network connections, we're probably the first group of people to spread the disease. And the argument goes that that lumpiness means that traditional notions of herd immunity have some challenges to them. I think that's a lot of truth in that. I think there's even more challenge to the notion of herd immunity. And let's separate out two kinds of herd immunity. Historically, epidemiologists talk about herd immunity, meaning what percent of people need to be vaccinated to stop the disease. And there's a formula, which is herd immunity must be greater than 1 minus 1 over R naught. So if the virus is spreading at a speed where 1 gives rise to 3, and that's your replication value, R, then 1 minus 1/3 is 2/3. So you have to vaccinate 2/3 of the people. That's herd immunity in that sense. A lot of people have been using herd immunity to mean what percent of people need to get the disease. That's not really an authentic historical use of herd immunity. In part, we don't know how long, and we can't control how long people are immune. We're not sure what inoculum kind of disease. There's other reasons for that. But Nick, you don't need to get to herd immunity to stop this effing disease. We never got to herd immunity with smallpox. And in some places where 95% of people were vaccinated, they had huge epidemics of smallpox. Likewise with polio. And the idea that there's so many asymptomatics that those rules don't apply. In polio, 999 out of every 1,000 people who get polio are asymptomatic. So it's not that. If we can find every case of COVID, and there's a good argument for the number in the United States, there are 3 million people in the United States. It's probably 2 to 10 million, but 3 million is the number right now we're using, that are infectious. Well, that means that 327 million are not infectious right now. If we could find those 3 million and vaccinate everybody that they are face-to-face exchanging air with, and vaccinate them with a 90% effective vaccine, the disease stops. And of course, if you add to that, you find everybody, you vaccinate them, and you isolate them, then even if the vaccine fails, you can still stop the disease. But that's augmented by what I said earlier, which is this post-exposure prophylaxis. If you vaccinate someone after they're exposed and it doesn't do any good, then you have all these other problems. But I agree with you. You're
somebody speaking.
The core question you do
Hope you're not leaving on a conversation.
effectiveness and equity. Is that right?
And I can't hear his voice.
Hello? My concern was that if you could show that there are strategies that are not the ethical strategies that give you, say, 5 to 10 times of effectiveness, that is, each dose of the vaccine is worth 5 or 10 times what it would be, who would make that decision? And
I don't know how to make that decision. It would be different, I presume, in different countries and different places. It is ironic that the history of that ring vaccination strategy, which was based on the most ethical decision-making process that I know of in vaccines, because Bill Foege was a missionary doctor in Nigeria during the war, and he had a very small amount of vaccine and a very big epidemic. And he had to make a decision of what was the most ethical distribution. And at the time, it was the richest and the most powerful people in Nigeria asking him to vaccinate them. And he, he thought that the most ethical thing to do was to give it to the people who are most at risk of getting the disease next. That is the same as the strategy of vaccinating a ring around everybody who is infected. And so his strategy and his final paper, which is called Selective Epidemiological Control, was based on on his own ethical struggle to make that decision. It's not an easy thing to sell. It's counterintuitive that you don't vaccinate either what Nick said, which is the most highly networked individual who maybe they're the people who are creating more clusters, super spreader events, or the richest people in the world who are making the most demands, or the poorest. But instead you vaccinate the people who are the most susceptible in the moment, and you remove them from the density of susceptibles. And I don't want to get too wonky, but the single biggest driver of an epidemic, is the density of susceptibles. I think the single biggest driver of a forest fire are the susceptible trees around it. That's not to say what is the cause of the forest fire, but the driver of it. If there's no other trees around and you have a big flaming, eucalyptus tree, it's not going to make any difference. There's no other structures to burn. It's the same thing with an epidemic.
Larry, Jesse Dillon has a question.
Jesse, where are you?
I'm in Los Angeles, up on the mountain, not coming off until everybody's vaccinated. Larry, it's good to see you too. We've had such a short period of time that we've created these vaccines. If before we started, we would have never thought that you could necessarily do it this quickly. What does that mean for the future of medicine? The things that are going to be possible that came from this giant spend that we've just done. And then my other question is, we say vaccine, but if you have certain comorbidities, what's the selection process for which vaccine I'm going to take or you're going to take? Or it seems like there's a lot of varieties, and how do we know, how are we going to go through a process for people just to select a vaccine? Because there's 2 on the market now, but I mean there's 150 coming.
Well, I hope you're going to call me, because you don't call, you don't write.
Well, of course.
So the mRNA vaccines, the 2 that are first out of the chute, the Moderna and the Pfizer vaccine, they offer not only a vaccine that is less likely to have bad side effects because they're not actually infecting you with a modified vaccine or an attenuated vaccine. They're just giving you a little bit of code that programs your immune system through the messenger RNA. To me, that's the most exciting of the many different kinds of vaccinology that have been pressed into service by the pandemic, because that's something that bodes, I don't know if it bodes well or is intriguing or quite exactly the right word to use, but the opportunity of using messenger RNA body to do other things is really exciting. There's a group called COVAX, which is doing a similar thing with a peptide. But so some of the science that comes out of this, I think, will that has the potential of being valuable, not just for vaccines, but for treatments, and not just for infectious diseases, but for chronic diseases as well. I'm really excited about that. Although none of us know anything about whether these vaccines are indeed safe. And let me just take a moment on that. We use the term efficacy signal. It's a shitty term, but it means does the placebo-controlled trial that you're doing with your vaccine in this case, does it show an efficacy signal? Does it show effectiveness? So let's just take the one study that did 30,000 people and did them into two groups. 15,000 got placebos, which is salt water in the same kind of injection, same color package, and 15,000 got the vaccine. And then they're allowed to go out into the world and get infected if they do, or not infected. It's not a challenge study. You don't vaccinate them and then give them the disease. And in this study, with 30,000 people, about 190 some odd people got infected. And of the people who got infected, more than 90% had not been vaccinated. So you convert that into what is your risk of getting the disease if you've been infected, and your risk is 9 times less than the other group, so it's 90% effective. That's the efficacy signal that we got from both Moderna and Pfizer, roughly. Allow me the rough part of it. Now, what's the safety of it? Well, you can't do the same thing with safety. Literally, these vaccines have been in trial for 3 months. We only know what side effects occur 3 months after you're vaccinated. And while it is true that the majority of side effects take place within a couple of months of being vaccinated, that is not true for the worst side effects, which may not happen for a year or 5 years. Some of you who are wonks may remember in 1976, 77, when we had a swine flu scare, and CDC vaccinated millions of people with an H1N1 vaccine that was rapidly created. And only after millions of people were vaccinated did we discover that quite a few people got Guillain-Barré's disease. And that entire program had to be pulled back. So that the real side effects of a vaccine that occur later, we can't know until later. These trials can give you an efficacy signal quickly, but they can't give you a safety signal quickly. There's no way to truncate that time into getting, and because absence of evidence is not evidence of absence, we can't prove that there's an absence of side effects right now. So that's something to think about. And it does that Vax question we had earlier as well.
I have a question for Jesse. In terms of communication strategies and the divisions of the country, I'm sure this is what we thought about. How do you present a vaccination program, or what thoughts do you have on the subject?
Well, I think it's too early to say. When I worked for President Obama, and then when Trump came in, we'd done a lot of design research on people's attitudes and feelings about Obama, and then Trump came in, and all of that had to be redone. Irrespective of political, well, I guess because of political beliefs, the feelings that people had were completely different when Trump was president. So I'm hopeful that when we and I've worked on it I've worked on warp speed, and I've worked on at NIH on a bunch of different things. So I'm hopeful that when this we make the change, when the government changes again, it'll change again, and people be more tolerant. Larry was talking about frontline workers. at the current time, only 40% of frontline workers are willing to take the, or 60% are willing to take the vaccine. So, you know, I mean, Larry, like, what is this sort of cognitive dissonance that people have about it, and what are the repercussions if like, let's just say half the country doesn't get vaccinated? What is that? What are the long-term repercussions of that for all of us?
I think they're both better and worse than we think. The question that we are being asked is an abstract question. Would you take the vaccine? It's not, your mother has just died in a nursing home, would you take the vaccine? And if the strategy of ring vaccination or selective targeting of vaccine around clusters or outbreaks is used, then the question shifts from the abstract, will you take a vaccine, to, oh hell, I've just lost somebody I love, or I know people who are dying all around me, will you take the vaccine? And I think that will change the calculus, the individual, every human being makes an individual cost benefit decision. And they're not it's not stupid, it's just your data set is different. So that
do people not remember? I mean, is it, you know, I had somebody in my family years ago who had polio. So that's always been in my mind since I was a little kid. But do people not remember what polio was like in this country, the things we don't see in the country now? So they don't think, well, you know, I'm not going to get vaccinated against polio, and then we get a resurgence of something that is so horrible?
I think you're answering your own question, really. You know, you have in your memory bank and in your life's experience, the experience of polio. That's less and less every year. You know, I think there are less than 25 cases of polio in the world today. So the lived experience of polio, which is indeed a major contributor for people's motivation to invest in a polio vaccine, do the trials for polio vaccine efficacy, and take the vaccine themselves, that diminishes. The lived experience for COVID, even though we've, you know, had just shy of 20 million cases in the United States and just shy of 100 million in the world, you know, that's a very small percentage of the population. So it's still true that more people have not had a family member or friend be hospitalized for COVID than have. That will change if the vaccine focus is on cluster control, outbreak control. And we can't do that yet with 200,000 cases a day going on to 250,000 in the United States. How on earth can you see where the clusters are? And what county health officer can go and investigate an outbreak and do contact tracing? I mentioned earlier that Vietnam's success was based on 100% contact tracing. A comparable figure in the United States is probably 5%. So how can we control a disease when we can't even see where the clusters are or the outbreaks are and find all the contacts?
I think we should think harder about that question.
Yeah, and what role do you play the federal government plays in all of that, possibly, Larry? You know, like, what is the role of the federal government?
Usually in another period of time, in an age with more rainbows and unicorns, I would have answered, well, CDC does it. It's going to take a little while to repair the damage done to CDC's reputation. That's the source of authentic scientific information historically. You know, I mentioned earlier on those WHO calls, what everyone around the world says is, welcome back. We missed you, America. They're really saying we missed you, CDC. We missed you, love of science and expertise and leadership in the field of epidemic control. It's the US and it's these phenomenal scientists at CDC that have always led our campaigns against infectious disease and epidemics. They're still there for the most part. Many of them have retired and left and tried to get out of the circular firing squad that the Trump administration brought to CDC. But many of them are still there, and many of them will be called back. A lot of them will be called out of retirement to come back, I'm sure. But that's where it'll come from, Jesse. I think that that the strategies, look, it is not just a political talking point to lament the fact we don't have a national strategy. And what Trump did in retrospect by saying ventilators, not my problem, governors buy them, testing, not my problem, 50 states compete with each other for masks, drive up the costs, make for scarcity. It isn't just the material scarcity that occurs when 50 states compete with each other. It's the intellectual scarcity and the fact that there's no controlling, no federal strategy. We had no national strategy to this day. The Trump administration's national strategy was not here, not me, not real. That's all going to change under a new administration. That would have changed under any new administration, and it will particularly be true under this administration.
I have a question for Danny Kahneman. As you recall, you spoke about the difficulty people have with the idea of exponentials a while ago, and all that's coming home to roost now. In your field, are people thinking about how to communicate, these issues that most people are not equipped to even think about? In terms of in the last 6 months, have you and your colleagues been thinking about this kind of thing?
I don't think I have much progress to report on this. Educating people to think about exponentials is not going to be easy, and I don't think it's at all feasible. It really is a matter of the policymakers. I mean, I don't think that it's the public that needs to be educated. There needs to be a strategy. There needs to be a national strategy, and there needs to be more respect for facts. So that's where the problems are. I don't think that the problem is the psychology of thinking about exponentials, which is that's not going to be fixed easily.
Danny, if I could, I just want to say the first time that John put you and I in contact, which of course was such a delightful moment for me. I asked you what you thought was the biggest problem that we would have in dealing with COVID, and you said that you'll be able to do a close down once, but once you've done that and you open it up, you'll never be able to get people to close down a second time. And God, were you right and prescient, and that has turned out to be one of the biggest problems that we faced.
I mean, that was really predictable and almost built in, because once you impose it again, people are conscious of unfairness, and they're conscious of being affected more than other people are, and why me and why not others, and whereas the initial lockdown was acceptable to everybody, but you really get fragmentation in future, and we're seeing that everywhere, actually. I was going to ask you, Larry, about Germany, because one of the things that have been very striking to me is that we had a success story and it doesn't seem to hold. Now, if the success story isn't holding, what is it? What is happening? Is it because Germany is not isolated, or because you really need to achieve a certain degree of eradication, which they did in Singapore and in other places, before you can really open up and relax?
Yeah, I think the success in Germany is due to two major factors. One is you have a scientist and an engineer as your prime minister who has been interested in pandemics and sponsored all of the G8, G7 resolutions and on pandemics for the past 10 years, way before COVID. So you got the perfect leader at the perfect time. And the second thing is that Germany had planned ahead with a national insurance kind of plan and excess hospital capacity. And as a consequence, never had the surge problems that we had elsewhere in the world where we ran out of capacity. There's a lot of other reasons too, but you're right. I don't know.
My question is about their difficulties now, not about their initial success.
Well, but
success was understandable, but why is it so hard to retain, and why have they been successful in the East and apparently not in Europe, not in Israel, where you achieve some initial successes and then it rebounds? What do we know about that, about the rebounding?
Well, as was said earlier, it's not just the East. It's Iceland and New Zealand are not necessarily in the East, but it's definitely those individual countries that have succeeded so well have each succeeded by a combination of practices that we would think of as best practices, culled from global experience. Germany was the first to make a test kit, and actually was a German scientist who made it and gave it to WHO. So Germany had a real leadership position early on. I think there's some kind of regression towards the mean going on in Europe in general. It's not Germany alone that has had a spike. It's Spain and France horribly, England until just about a week ago. So I can't answer your question. I don't know the answer, but it may be that you, as you say, you never got it down to a low enough number that outbreak control alone could offset the continuing importation of cases from outside the country, which is what fueled it. It wasn't just community spread. It was a constant reigniting of new forest fires that led to the larger conflagration that we're seeing right now.
So, I mean,
Is it that the Europeans just said, as July looked good and better, the hell with it, we're going to have a regular August. We're going to Liguria, to the sea. We're going everywhere as we always do. And no masks, no social distancing. Hallelujah.
No one knows the answer to those questions, but my best guess is that the school semester that begins in the autumn will be a normal-ish school semester, that kids will be going back to a few camps during the summer, and that wealthy, elite, well-connected individuals and wealthy countries will show islands of normalcy, normalcy being no COVID, and the world will begin to look a little bit like Swiss cheese, where the holes are COVID-free zones, and the yellow meaty part of the cheese is the rest of the world, until those holes coalesce, and then counties are free, states are free, countries are free, and then they'll erect borders, and then there'll be bubbles that are made between countries that are free. Recently, an interesting experiment between Hong Kong and Singapore to create a bubble of travel that fell apart, but there are such experiments going on between Australia and New Zealand. I think it'll grow from the holes in the Swiss cheese to the rest of the world, and we will eventually kick this disease into the dustbin of history, but it won't be without going through hell in the next couple of months. And I don't know, we have some logistical issues with taking vaccine production up to scale. And the better vaccines, the Moderna and the Pfizer vaccine, will be the hardest to get to scale. Vaccines like the AstraZeneca will be easier to get to scale because it can be made in these huge factories in India, and it's a vaccine made in a way that other vaccines have been made before, not novel in every way, like the mRNA vaccines are. But it'll take the world being free. I mean, I'll say what everybody knows. If there's COVID anywhere, there's COVID everywhere until we have these islands of freedom.
Carlo?
Thank you, John. I have a question to Larry and to all of you who understand these things, hopefully far better than me. It's a very general question, so it's obvious the answer is not going to yes or no. But I'm generally confused because I've also been talking and writing about that, and if you help me to clarify, the question is the following. So let me distinguish two things. One is the foolishness that we have seen, obviously, both in some government and some political forces in a lot of people, of ignoring scientific facts, willing to believe things which are not true, and so on and so forth, and just put it as large as you can. So I see that very well, very clearly, and it's obvious the damage that's done. But let's try to forget that for a moment. I mean, suppose people were not foolish. People were reasonable. People were all, just for a moment, for the question I want to ask. The question I want to ask is the following. If you forget that, is the problem of defending ourselves from this pandemics just a technical problem or not? And let me say what I'm saying, what I mean here. I have the impression that some societies have found themselves in a choice. How can I put it? Let me put it brutally, between saving more lives and making more people poor. I mean, things are far more complicated than that, obviously, but that's we put it brutally. Now, if the choice is between having more people dying and having more part of the population that become poor, that's a political choice. It's not a technical choice. I'm in favor of saving people, no doubt. So I would be happy to live in Taiwan or in Vietnam and going through political choices which I share and I'm happy with. But I do understand the argument of those who says, wait a minute, okay, if some old people die or some people die, if in exchange we can avoid impoverishment of society. And then the problem becomes political, not technical. So the question I'm asking is that let's separate for a moment the foolishness of ignoring scientific facts. Beyond that, is there also an issue in this pandemics which is political, is not technical?
Of course. But I think the distinction without a difference. I think the historians will look at the Swedish experiment, which is sort of an encapsulation of, one form, and they'll look at it as one of the great tragedies. And it's because you can't get there that way. You can't get to economic growth without solving the problem of a pandemic. History shows that in every pandemic in every place. Now, there's two differences here. There's geographic spread. This is really a pandemic. This is, the plague of Athens didn't go much beyond Athens. This is so you have to look at, can I isolate my entire country and isolate it from the effect of the pandemics all around me? And islands can do that better than countries that are contiguous with land masses or have open borders. The other is time. So it's geography and time. Once you have a vaccine or vaccines in sufficient quantity and tests in sufficient quantity and treatments in sufficient quantity, which we're going to have in a matter of months, I think this argument disappears. And in fact, it is a lack of confidence that there would ever be a vaccine or ever be a therapeutic that does give some strength to the question you're raising. Because if you think that there'll never be a vaccine or a therapeutic and that this state of a pandemic is permanent, then of course the choice between economic well-being and death rates become much more cogent. But once you have those, as Tony Fauci says, the cavalry arrives. Once the cavalry arrives in terms of the prophylactics, preventative measures, and cure, then they're the same thing. If you don't bet on there being a vaccine or a treatment, you might make that choice. But I think it's I don't think it's a real choice. I think it's a false choice. And certainly in retrospect, it'll look like that.
I have a question, Larry. Hi. So I'm wondering, and just going back for a moment to the German perspective, because we have a country where we can trace, I'm not sure how much, but I think a much higher amount than in the US right now in terms of cases and outbreaks and where they're coming from. Would you advise those kind of countries who have tracing capabilities like this to advance a strategy of vaccination, which is more in line with identifying current people infected and the people that they've been exposed to? Because from what I'm understanding, in the German discourse right now, that's never been discussed fully, and that's not really something that they're looking at. When it's been very interesting hearing you today, that sounds like an incredibly appealing alternative, particularly if they actually have a pretty good handle on outbreaks and on tracing those outbreaks.
Yeah, that's a really great question. It depends on what vaccines pass the hurdle of being effective and whether they have this post-exposure prophylactic characteristic or not, or and how easy they are. So, for example, if you have to get 2 doses 1 month apart and then an annual booster dose, the idea of using vaccines as part of outbreak containment becomes a little less valuable than 1 dose, never have to find the same people again, and no annual dose needed. But this idea of the hammer and the dance, a wonderful way of looking, or at least innovative way of looking at how you deal with shutdowns and closing the economy for a short period of time, and then dancing with all these non-pharmaceutical interventions like masks and social distancing and hand washing and outbreak containment. That becomes more important in this context. I think if a country can find every outbreak, let me say it a little differently. I'm going far afield again, but Warren Buffett said, until the tide goes out, you can't see who's swimming naked. Until the tide goes out of the epidemic, you can't see where the rocks are, the outbreaks or the clams, or you can't see anything. It's covered by a tide. You can't do outbreak investigation. You can't do testing, tracing, and isolation. If Germany can do that, then as certainly Taiwan and Vietnam and Korea and New Zealand can do that now, then the idea of the hammer is over. It's done its job. Now you can do a different dance because you have a vaccine. Then it would be absolutely appropriate to take a look and see if ring vaccination or targeted vaccines would work. You could start off by just doing testing, tracing, and quarantine and vaccination until you have a vaccine that could carry more of the burden itself. But absolutely, you've made this investment to gain control of the epidemic. You might as well now profit from that investment that you've made.
Larry, does any epidemiologist think about whether you could understand this well enough to predict where the outbreaks will be, to predict who will get infected?
Yeah.
not exactly, but probabilistic.
Probabilistic. Yeah, there's a number of people. George Dylan George at he used to be at BARDA and he's now at InQtel, has been trying to launch a global weather service that predicts where the pandemic will go next. There's a lot of people at MIT who are working on stochastic processes and predictive models. Jeff Shaman at Columbia University has done a really good job on that. I think Sam Scarpino at Northeastern has done quite a bit of that using mobility. In fact, he's published extensively on the Wuhan outbreak using only mobile phone digital vapor trails to predict where the outbreak would have gone, and then looked at real data and seen a congruence in what happened with following mobile phone digital vapor trails. Yeah, I think it's really good. I think, again, it's a little bit like we were talking about with Germany right now, is until there is a reduction in the ocean, the tide, the huge amount of disease, it's not going to help you very much. But it's extremely valuable once that ambient viral load goes down a little bit. Let me say it a different way. If we have 250,000 cases a day or 200,000 cases a day, and the average infectivity is, let's say, 5 days, that's not right, but let's say that. So you have 1 million people who are sources of the disease right now, and you have to contact trace 50 people for each of them. That's 50 million people you have to find and locate their address, and then you can predict where it's going to go next. It's just overwhelming. We can't do that in the United States right now. You can do it in Germany, apparently. You can do it elsewhere.
The information is there. The information is in the phones.
Yes. Yes, the information's in the phone. It's also in kind of funny things like you can, what Sam Scarpino just published is he found that there were super spreader events that included particular churches that had particular practices, particular restaurants that had particular seating patterns, particular, not tourist attractions that created the opportunity for super spreader events. He's one of the people who investigated this outbreak in Maine. Yes, I think that it's entirely possible to do a probabilistic prediction pattern, and as the load of the epidemic becomes less, I mean, Germany perhaps could do it right now.